Hello, my name is Chris Cox. I'm a teacher. I'm going to teach you today about interosseous infusion. Our assignment was to pick a skill that we don't usually use, or one that's our favorite, and to use it, to show how it's done, and to explain it in detail. Today we're going to do, like I said, today we're going to do the interosseous infusion. This is possibly the fastest, if not the second fastest method of introducing fluids and IV medications into the body, IV being the other one. This procedure here goes into the bone and goes into the bone marrow, into the interosseous space, and allows the fluid or the medication to be absorbed into the body a lot quicker. Some components of the IO, as we're going to call it, is we have an IO gun. It's basically just a drill with a battery. And as you can hear it, it sounds like a little dental drill. Some other components that should be in the kit are you'll have a saline lock from which to attach your IO and to push medications and fluids through. There are 3 types of needles in IOs, 3 different lengths. The smaller version here is a ped needle. This is what we would use in a pediatric. Most everyday human beings, every day of the week, are going to use this blue needle. This is an average length to infuse fluids and things. And this one right here, this one's for your larger people. It gets into a lot deeper and allows you to get good coverage. You should also have a magnetic, some kind of thing to arrest your sharp so that you don't hurt yourself. I also have an example here of a manual IO, also called in some circles as a Jamshedi needle. This one you would use by hand, screwing it into the same area of the bone. It works the same way, it just doesn't have the electric drill. So first off, you want to see the need for an IO. Your first need with an IO would be if they're an unstable patient. Say in cardiac arrest, low vitals, a person in shock that you cannot find an IV on. This is a rapid intervention. This is also a very ugly and sometimes people call it disgusting intervention because it is very invasive. So today what we're going to do is we're going to learn why we give it and when we give it. You'll give it in possible cardiac arrest. You can give it in possible diabetics that have a low blood sugar where you cannot find a vein. You can give it in car accidents for people that are unstable so that you get fluid and blood to them. You can give it in other health CHF emergencies, breathing emergencies where you need a rapid means of getting medication into the body and you don't have time to get an IV, or you're unable to find a place to do an IV. I'm not saying this should be used all the time, every time, but there are needs for it. And yes, I have used it in the awake patient. Most people use this on are not alert and oriented. So the IO is placed in the state of North Carolina. You can honestly do 2 places with the IO. You can do one in your proximal tibia at the tibial tuberosity at the top, and you can also do one in your humerus. But in the state of North Carolina, we're not allowed to do humeral IOs. So that is why I have an example of the tibia. As we know, the tibia is your largest bone in your lower leg. On the inside of the tibia, just below the knee and sort of medial to the bone, is what we call the tibial tuberosity. And it is a flat place on the bone. And if you can all feel down on your leg, I'm not going to pull my leg up for you, but if you pull your leg, you can feel on that bone, the flat spot in your leg just inside. Usually we measure by going to the kneecap. You take 2 fingers and go down, and you take 2 fingers and go over, and that'll give you your tibial tuberosity. All right, so you've decided the need to do an IO procedure. We're going to use this as our bone. So you would get your gun out, and every morning you should check this. I know some people say that you're not supposed to because it only gets a certain amount of pulls of the trigger before it dies. But my thing is, let's make sure it works before we start with it. So, and in this person, we're going to use the the medium version of for the normal size human being. I do not have gloves. The first thing you should do is make sure your scene is safe. You should have your BSI donned. Unfortunately, I do not have gloves. Miss Connie, you can count me off on it. So what you do is you decide that you need the need for an IO. You attach your IO. You pull your IO gun out, and this usually comes in a packet. It'll come with this, with your saline lock. It'll come with a sharps container to put or a sharps way to rest your sharps, and it'll also come with usually like a Tegaderm. It'll come with some gauze. It'll come with some tape. We do carry at Pender. We carry a manual IO stabilization kit that goes with it. There are different versions of the IO. This is the one that's made by. This is the Easy IO. This is the brand we carry. There are other brands out there. This is the one I'm most familiar with. So what we're going to do is we're going to attach this. It actually has a metal piece in the bottom that fits on this little stop right here. Okay, so you're attached and you pull it and you see how it spins. Okay, now find your patient. 2 fingers down. You get the 2 fingers down. You come over 2 fingers from the middle, and that gets you into your tibial tuberosity. You prep the area by using an alcohol swab. Once you have the area prepped, you take your IO gun and you insert the needle. You do not pull the trigger at this point. You insert the needle into the skin until you feel the needle hit bone. And as we see here, it's a little thicker than we thought, but there we go. So we've hit the bone. Once the needle has hit bone, you pull the trigger until the bone drills in, and you'll feel pressure, and then you'll feel the pressure release. You should be in the interosseous space at this point. You remove your gun, save the gun because you'll need it for future calls. Now you unscrew the hub. You maintain contact with the bottom half, and you unscrew the center. This pulls out a needle that makes this a hollow needle. You pull this out. I'm not going to put this in the sharp because we use this for training purposes, and I do not want to have to get another needle. And you would arrest your sharp so that you're safe. I sometimes, if I don't have this out and it's been kicked, it's a wood floor, I usually stab this in the wood floor and we clean it up afterwards. That's a bad habit, but that's what I do. Now, once you have this, you take your saline lock and you screw it onto your hub. Now, in the real world, I would have a 10 cc syringe that I would probably pump out about 1 cc of fluid out of it. I would attach it to my saline lock, and I would draw back. And what I'm looking for is marrow. Marrow will be, sometimes it'll be red in color, sometimes it'll be amber in color. You might even see some little bone pieces in it. You pull this back to make sure you're in the tubule, into the marrow, into the interosseous space. Now, you push on the syringe, the flush, and you flush the line. You're 2 parts of this. You're trying to make sure the line is flushed, and you're also trying to make a space inside the interosseous space. Think of the interosseous material as a jelly-like substance. Kind of makes medications hard pushing, but if you make a little space, it makes it a little easier. If the patient is actually alert, you can give them some lidocaine. I think the dose for lidocaine is about 1 milligram per kilogram through that IO. Kind of deadens the pain a little bit. So once you've flushed it, you can crimp it off with a little lock so you don't have air and stuff in it. You can hook up your fluids, you can hook up your medications, and start to push. Like I said before, you're going to have some issues pushing it at times. Sodium bicarb is the worst to push through this because it is a big ampule of sodium bicarb, and to push that into that little of a space, it takes some work, it takes some time. D50 is another one that is tough just for the simple fact that it's so viscous and thick. You can push any medication through an IO that you can push through an IV. There are no restrictions. This is basically an IV the quick way. Once you have the IO in place and you've realized that you have aspiration, you've aspirated some bone marrow, and you're actually pushing drugs, you want to get a stabilizer. I do not have a stabilizer with me, but think of it as a big triangle that's kind of cardboard plastic type thing that you sit over top of it and you tape it off, and this keeps this thing from being moved. You also want to write on it what time you gave the IO. I personally have not done that much. Once the IO is in, you do not want to remove it. The doctor will remove this IO if he sees fit. A lot of times they leave them in when we get to the hospital. Once you have that, you can push your medications through it, continue to tape it, continue to monitor it. If you do miss one, it happens. You can remove the needle. You can remove the needle by it's basically just screwing it out of the bone, because you screwed it in, so you got to screw it out. So once you get it out of the bone, make sure you rest your sharp. Like I said, you have varying ideas on this, varying things on this. And I will, at this point, put the sharp back together. And I know Miss Connie's probably cringing right at this moment, but this is how we do it. And I will attempt to use the Jamchetti needle just as another way of showing an example. This one's a little on the broke side, but like I said, it's same with the Jamchetti needle as this. This is just a mechanical version. You use your 2 fingers down from the kneecap, 2 fingers over. That usually gets you into your tibial tuberosity. Also you'll feel a flat spot on the bone. You take your Jamchetti, you stick it into the bone until you hit the bone, and then you screw. And this one's probably duller than you don't know what. Once you get it in there, you'll feel it pop. You'll remove the sharp by screwing this part down. And like I said, this one is broke because we use it in practicing with them so much. You pull the center needle out. Once you get it unscrewed, your center needle is out. The needle is still in the bone. This is where you would hook up your flush and continue on just as you would another IO. Like I said, this is just a mechanical version. So to review your IO skills, they usually come in a case like this. This is attached inside and it's got a little holder. Some of them have this little thing over it. Depends on where it's at. Who's messed with it last, it might not. You should have 3 different varieties of 3 different lengths and gauges of IO needles, a sharp arrestor. You should also have a flush and and a medlock. Once you have all this, you go to you look for the need for an IO, your cardiac arrest, your diabetics you can't find veins on. You can use this on breathing problems. Anything, you use this on the alert patient. There's actually videos out there that the doctor that actually went through this does it to himself. There's a guy on the military channel that actually does one in his chest. So this can be done. It is very simple skill to use. Like I said, you find the knee. This is the top of the tibia. This is the tibia tuberosity. You go to you find the kneecap. I usually go 2 fingers under, 2 fingers over. You'll feel the flat spot. You'll attach your needle to the gun. Okay. You'll prep your site with some alcohol. You'll place the gun to the bone till you pierce the skin till you feel the needle hit bone, and you just pull the trigger. You don't have to put any pressure. It goes in, you feel the pop, you release, you rest your sharp. You would stick it in there to rest your sharp. You apply your lock. You use your 10 cc syringe. You aspirate some marrow. You might not aspirate marrow, just to give it a heads up. You might not aspirate any marrow at all. You flush. Sometimes, and especially in kids, you can feel behind if you've missed or gone through the bone. You can sometimes feel it push on the other side out. You flush. You can push your medications at this point. So that is my presentation on the interosseous infusion. I hope you learned something. I hope this video was helpful. I know that it is for Methodology 1, Miss Connie. And thank you very much. being there. And yes, I do have British art on the wall. I am a British fan.